A very warm good evening to all the Johnites who are joining us here. This is a special initiative by the St. John's Medical College Alumni Association. We are back with a sort of a new venture which we hope to carry on into the future. You could say that we are in the clinical trial stage of phase 1 today. We are talking of voices from the outreach. St. John's is known for its rural mission, the healthcare it delivers to the far and the hinterland of this country. And who better ambassadors than the students who are serving out there in the rural area? Towards this end, on behalf of the Alumni Association, we would like to engage more and more with those serving in the rural areas. Before we go further with today's event, I would like to invite Dr. Anthony Robert, President of the St. John's Medical College Alumni Association, to say a few words.
Good evening, dear Johnites, and at the outset, a big congratulations and thank you to Nitin Yashas for conceptualizing this program and for Prithvi for being the backbone of our outreach. Our focus has been on rural health in various outreaches, and I think this is a very valuable experience to listen directly from those of you who have worked and who are working in the rural hinterland. So all the very best. Without any ado, please start your program.
Right. Fantastic. So this program does not have a really set agenda. It's not a formal program. We just want to sort of move forward by setting a platform where those who are serving in the rural areas of the country have a platform to sort of speak, exchange thoughts, exchange interesting ideas as such. Those of you who are logging in and who want to join in, please do post any comments that you would like in the YouTube comments box, and you will be able to, and our panelists and speakers will be able to sort of address those issues. We have got two very interesting cases today. We have got Sankalp from the batch of 2016 who will be presenting an approach to case of burns in the rural areas. Thank you, Sankalp, and thank you, Charan, from the batch of 2017, who's going to be talking about a very interesting, challenging case of cutaneous tuberculosis, which will be facilitated by Mihika. We'll also have Dr. Royson and Dr. Murtuza joining us shortly. And of course, towards the end, a very, very special guest, Dr. G.D. Ravindran, will be joining us. So I'll now leave the stage open to Charan and Mihika to take forward a sort of a very informal discussion on this case of cutaneous tuberculosis. Charan and Mihika.
Hello. Hello.
Charan, you're audible. Go ahead.
Hello.
Yeah, we can hear you. Go ahead.
Hi, good afternoon, everyone. This is Sarada Charan Bardhan, 2017 batch Johnite. I am going to present the case of Cutaneous TB that I have encountered in my rural burn center. A 21 years old male student by occupation presented with complaint of blackish lesion over the malleolar region of the left leg for the duration of 1 year, associated with severe itching. The lesion was gradually increasing in size. No similar lesion in another part of the body. No history of fever, cough, weight loss, and evening sweating. No history of swelling in the neck, axilla, and groin. No history of altered bowel habit. No family history of TB. No history of prior tubercular treatment. There was a well-defined plaque 4 by 4 centimeter in size with irregular margin, with some areas showing atrophy and some areas showing hypertrophy. The plaque shows advancing edge, which was hypertrophy, and receding edge, which was atrophy, associated with scaling. The plaque was indurated. There was no associated discharge, no local rising of temperature, no surrounding skin. Surrounding skins are healthy. No evidence of localized lymphadenopathy, no other cutaneous lesion. Patient has been treated with topical steroid and combination cream.
Charan, just to stop you there, very well presented. Do you have any photos which you could share?
Yeah, yeah.
Mika, you're on
Hello,
mute.
ma'am, can you share,
About the
please?
picture.
There's something called as present. So if you click on that, you'll be able to share the photo.
Uh, Ma'am, you have photo?
I have the photo. I'll just share it 1 second.
Sure.
Uh,
So Charan, where exactly was the lesion located? In the leg, is it?
yes, sir. In the left leg, above the medial malleolar lesion.
A lesion present in the leg above the medial malleolar lesion. And what color was it looking?
It's a blackish.
Blackish color lesion above the medial malleolus. And around the area, there was no other redness, there was no scaling or itching. That is what you mentioned, correct?
Yeah, yeah.
Correct. Okay. I just want to sort of to also give an opinion. Roy, thank you so much for joining us. You're on mute. If you sort of see a blackish lesion above the medial malleolus in the leg, what are some of the differential diagnoses that you would think of?
Yeah, thanks, Nitin. Hello, Mika, and everybody. So the most common condition that you should think of with some blackish lesion in the foot is it like an impending ulcer in our population, which are predominantly diabetics. So then you look at whether it's an infected ulcer, is it an ischemic limb, is there an arterial insufficiency, and very, very classically, chronic venous insufficiency, in other words, varicose veins, will have these lesions located in what we known as Gators, what we call as Gators area. So there are various stages. So you may have heard of lipodermatosclerosis. These are the lesions that happen much before the ulcers come, and eventually they lead to shallow superficial ulcers, and then with a inverted champagne bottle appearance kind of the leg. So remember, diabetic foot ulcers, ischemic ulcers, and varicose ulcers. So in this patient, I think varicose ulcers would come first in the differential, followed by a diabetic ulcer or ischemic ulcer.
All right. Mihika, coming to you, we will obviously try to put up the photo which you have shared in the group as such.
Uh, so what is important to note is when you use words in dermat, they have certain connotations. So Charan, when you use the word blackish, it would imply a melanoma. So when you're referring to skin, you would typically refer to something that is a little darker and hyperpigmented. And when you describe the lesion, just so that people don't get sidetracked by other things, you need to mention that it's a well elevated plaque. So when we look at venous ulcers and stasis ulcers, they're not elevated, they're not edematous as such. So this was actually a well-defined plaque with further elevated borders, which was scaly. So you can see there are areas of central atrophy and this thing, but there are no ulcerations as such in the area. So you can see the margins over there with the thickened scale. So you not refer to this as a black lesion. You say it is an erythematous to hyperpigmented lesion because you can see the background erythema with raised borders in some areas of atrophy. Now there are certain pointers here. One is the site and the fact that it is a solitary lesion. Usually stasis changes are not very often only associated with one limb. The second thing is the age of the patient. The patient is 29 years old. It's very unusual to have a varicose ulcer at 29 and 21 years old in a 21-year-old college student. So when you actually look at this lesion, I would think of three things. One is a deep fungal infection. Mycosis granuloma also presents in this area, but the raised portion would be around the follicles in that. Here you can see it's more around the margins. And you would think of cutaneous tuberculosis. Now, how you'd approach this from this point would depend on the level of your bond center. So in some bond centers, you'll have absolutely nothing. You don't have investigations, you don't have anything. So in that case, if you see a patient like this, particularly given the back context that the patient has had a topical steroid use.
Just to stop you there. Charan, when you saw this patient, what were your first thoughts and how did you go about approaching this case?
Sir, first I took the history. Then I asked for any other things. I asked for a treatment history. He was using steroid and some combination cream and histamine for one month he has used, but there was no improvement. Then 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 I thought after give all this treatment, I thought I'll go for these things, Mantos test.
Okay, okay.
So
And why
actually,
did you, yeah, why did you think of doing the Manto test?
Sir, the plaque saw that advancing edge was hypertrophy and receding edge was atrophy. So I thought it may be cutaneous tuberculosis. Maybe my differential diagnosis was cutaneous tuberculosis or other with Majochis granuloma, that is long-standing fungal infection.
All right, fantastic. Amika, please go.
so actually, when Charan had seen the case, his initial differential, I think, was lichen simplex chronicus, which is a very good differential diagnosis to make given the location above the malleolus. That's an area it's accessible, and people, once you get a small bite, tend to scratch on it. But one of the important things to notice that is that the lesion is not actually lichenified, so you cannot see a generalized thickening that you would normally associate with lichen simplex chronicus. So that's why we thought of investigating, and based on what was available on his center, we suggested a MAN2. Otherwise, typically, I would go for a biopsy first if the facility is available.
All right. So, if you were to give away 5 take-home messages when someone sees a lesion like this, what are some of the points that those serving in the rural areas must keep in mind for one, the differential diagnosis, and second, the management forward?
The first thing that you have to notice is it does not look like any of the standard conditions that you would treat with a steroid. So it doesn't look like eczema, it does not look like psoriasis, it does not look like lichen simplex chronicus. So the first thing you have to do is keep a steroid away from this. Because the more you immunosuppress the area, the worse it's going to become, even if it had turned out to be a deep fungal infection. The second thing that you have to do is your evaluation will entirely be based on your resources. So if you don't have facilities, the faster you refer, the better it is for your patient. Don't try to handle things that you're not equipped to handle. If you are in a well-equipped center, I know people in Guddu, Sitlingi and all, they do the biopsies and send it. If you have the facility for a biopsy, go ahead for it. If you don't have the facility for a biopsy, at least rule out tuberculosis. You can do a MAN2. It's important to remember that all cases of cutaneous tuberculosis may not have a positive MAN2. In Charan's particular case, there was a 25 positivity. So then we were 100% sure this was tuberculosis. But that may not always be the case. So if your MAN2 is negative, go for a biopsy any which ways. And the last thing that I want to say is just because we think of TB with systemic manifestations, fever, cold, cough, and everything, primary inoculated TB, which is the TB which is inoculated into the skin, which can occur on trauma, may not have any systemic features. That might be the first lesion that the patient comes with. In case of lupus vulgaris or scrofuloderma, there might be an underlying systemic TB. So just because your systemic examination is negative does not mean that you should rule out tuberculosis in the first go.
All right. Okay. So just to summarize and give clarity, most important thing about cutaneous TB is patient may not have any systemic manifestations. Second point, MAN2 positive, negative, always try to clinch the diagnosis by biopsy. And third, look for these characteristic skin features with regard to the edges, the sort of margins and the central area to think of a diagnosis of cutaneous TB.
Yeah.
All right. Okay. Charan, what are the sort of challenges that you face when dealing with dermatology cases in the rural setting?
My cases are here. So there is not sufficient test I am doing here, like the rural centers only CBC, all these things is there. For this biopsy I have to send outside, not in my center, nearer to town. So all these things I am facing here problems.
Mihika, you have worked in centers with extensive number of dermatology cases. You're still helping out all those in the rural service areas. What do you think are the challenges and what can be the solutions to these challenges of trying to handle dermatology cases in the rural setting?
One thing I think that's really important is to get a good tie-up with a nearby lab. to do a skin biopsy is not a very invasive procedure. So, like, I agree. In my center, it might have been almost impossible. My center was a mobile health unit. So, doing a biopsy there was kind of difficult if you don't have support and setting. But in most centers, if you have a minor OT or you have a dressing room, you'll be able to take a small piece of skin for a biopsy. So, if you have a district hospital or you have some method of collection, I would suggest try and get a tie up with a pathologist in that area where you can send biopsies for. The second thing is if you have a side lab and they're proficient with doing things like peripheral smears and all, the same smear which you can use for your peripheral smear can be used for a Zank. So making a Zank smear, sending the photo, we are happy to look at the photos and help you. The third problem is more of a problem that I face on this end is very often like I will get a picture like this with no background. So I don't know how long, when. So very often we think of, dermatology is an image based thing. So if I send the image, the diagnosis can be clinched. But that does not help us with things like triggers. It does not help us with things like etiology, which will prevent a further relapse of a lot of the conditions in dermat. So thorough history taking can often make up for a lack of investigation. So say you can't do IgE, you can't do patch testing, you can't do all of these things. If you have taken a well done history for all forms of exposure, you can actually rule out quite a few causes of diseases.
Okay, one very important question which you briefly covered when sending photos on the WhatsApp group, the Johnite Academics WhatsApp group, or individually to dermatologists. What are some of the key points that those sending the photos have to keep in mind?
It should be a good resolution photo first and foremost. If the lesion is blurred, I cannot make out the morphology. It should be taken without flash, preferably a natural light. But if the patient has come in the night, you can take it. Do not shine a torch in all the pictures. You can take one picture with a torch and one picture without the torch. The torch just helps us to know whether it's elevated or not. It's the tangential light of the torch. Don't send me the picture with the torch shining on the lesion because then I cannot make out what it is. Provide a history, at least how long the patient has had the complaints for, whether it's itchy, non-itchy, any systemic symptoms. Very often our conditions are autoimmune. So they'll have joint pain, they'll have oral ulcers, they'll have fever, malaise. So these kind of important history and all medication history. You might think it's not important to tell me that the patient is on sitagliptin, vildagliptin, but quite a few cases of unexplained itching are caused by drugs. So you need to tell me what medication, including medication that you might think is irrelevant to dermatology.
All right. Fantastic. So with that, we come to the end of the first case presentation for today. Thank you so much, Charan and Mihika. Charan, would you like to share any other experience and how do you think the Alumni Association or people from Johns and abroad can help to those in rural service?
Sir, here I am doing my bond center in West Bengal. It's a very rural area. So we have one Johnite group, rural group. Is there any difficult case or something? I put there my case history, all these things I put there in the Johnite group, rural health group. Even Sanjeev Luins are also there. They all are helping me well. All are. So any dermat case also anything doubt I ask Mika ma'am. She's very she's helpful. She's helping so much. And patient also they are keep coming. They become cured. They keep coming.
All right. So how is this patient doing? Any follow up has happened so far?
Yes, sir. It's follow up is happening. Patient was referred the high clinical suspicion for cutaneous TB. So we refer to higher center for further evaluation for systemic TB as well as stating ATT.
All right. Fantastic. Right. Thank you so much, Mika and Dr. Charan. We now move on to our second case, and I would like to invite on stage Dr. Sangal and Dr. Royson. And this is something which we sort of face, which is a very interesting and a difficult scenario which is faced in the bond centers, which is how do you approach patients with burns. Sangal, the stage is all yours. We have some questions and comments coming in. Very interesting Um, coming in from Samrat. The conversations one can have with such patients regarding plan and what to do when the patient insists on medication or topicals. We will take this question at the end of the thing when we will have all our panelists back on stage. Right. Sangal, if you can go ahead with the case that you had and Royson can facilitate it.
Hi, good evening. Good evening, everybody. Good evening. Thank you, Dr. Nitin, for giving me the opportunity. This is really great. This case itself is really close to me, and because it's one case, but I am seeing it as one case, but for me, I have learned a lot from this case. And also, thanks to Dr. Royson for actually helping me through. We wrote one case report, and he immensely helped me. He still keeps helping me in a lot of surgical cases. So thank you for that, Dr. Royson. I'm gonna start. I'm just gonna keep it short. I'm just gonna touch upon the important challenges I face and what of the condition of the patient came in. So basically, this was a patient who was a female patient in her mid 30s. She actually was a case of thermal burns in her workplace. She was a tea garden worker, and she was working in the garden, and there was a pit which was full of burning leaves, and unfortunately she fell in it, and there was at least 2 minutes or 3 minutes she was inside the pit, but she was promptly pulled out by her colleagues and she was shifted to the nearby government facility hospital. So basically our setup here is it's like a 30-bedded hospital here, and this hospital is in the middle of a tea garden, and like we have to go at least 8 kilometers off the place, and then only we can get civilization. Basically, it's a pretty rural place, and people are really like they cannot afford basic healthcare. So this patient, she was also equally poor. She couldn't afford healthcare, though she was referred from her primary healthcare center of the tea garden to a higher center, a center which is equipped to manage cases like hers. She was actually a case of 35% to 40% second to third degree burns wound, thermal burns wound. Uh, According to like we found out by the rule of nine. I actually went through the internet, and then for the first time I sat down, drew the chart, plotted the whole this thing, the rule of nine, and then came to the conclusion that she was having that kind of percentage of burns. Then I was fortunate enough to actually see a little bit of burns cases in emergency while I was posted in John's, because John's I never knew that John's is one of the few centers which are recognized by the government to provide burns treatment, and there are very few centers in all over India which actually are authorized by the government to actually provide healthcare, burns related healthcare. So what happened in this patient was the patient was wheeled in. Her GCS was normal, 615/15. She was vocalizing. There was no signs of airway injury, but she had the thermal burns in her chest and her abdomen also. So it was like a huge area. So I was worried whether eventually she will have contractures which might end up having breathing difficulties for her, creating breathing difficulties for her. But we went ahead with initiation of fluid resuscitation. Basically, the patient's attenders were very adamant in keeping them here because of the financial constraints, and so we talked them uh, through, and we were like, okay, these are the scenarios, these are the facilities which are available here. We cannot provide ICU or ITU facilities if at all she needs it. So, but they were still willing to take the risk. We went ahead with the fluid resuscitation according to the Parkland's formula. I calculated, and within 24 hours, the patient actually had a kind of a decent urine output. So the patient initial in resuscitation was done. So initial resuscitation is very important for any burns patient. That actually determines the course of treatment or the morbidity and mortality. It sums up everything. If that is not done well, the patient, even if the patient goes to a good facility after 2 to 3 days, it's very difficult to save a patient, especially 30 to 40%. And as I was taught, more the burns percentage is more than 40%, 50%, the morbidity and the mortality significantly increases. So the case itself was really challenging. The patient, uh, we had to do dressing every day. We had to scrub in. I was personally looking through the dressing, and I taught the nurses. The nurses were not at all equipped to do a burns dressing. The burns dressing is a little different. With paraffin, you have to keep it wet, and also you have to, at the same time, you have to make sure that it does not have infections. Wet wounds are very prone to infections, especially fungal infections, and so that was a challenge. The but but I had pretty amazing staff here. They were pretty quick in adapting my ways of dressing the wounds, and
So
every day
just
we did.
Royson here. You mentioned the challenge is in dressing of burns patient. Royson, are you there?
Yeah, Nathan. Yes.
Yeah, yeah. What are the five take-home messages you would give to anyone in the rural service with regard to dressings for burns patients?
So I think before dressings, what Sankalp also really correctly pointed out is the emphasis on fluid resuscitation, because that's really what kills the patients. So in rural hospitals, even though you don't have a theater, you don't have big dressings, please at least before referring the patient, make sure that they're covered and make sure you give the fluid resuscitation. Often, what happens, I've seen even in medical colleges, if there are not enough beds, we go into the ambulance, see that, oh, okay, it's 50% burns or it's 30% burns, refer the patient elsewhere, and you know that the patient still doesn't have an IV line. The longer you're going to wait, the patient's going to get all bloated and edematous, and you can't even get an IV line. So, rural areas is where your first point of care may be there. Make sure you get at least like two broad gauge IV lines in, and give that first liter of saline. If you can put in a catheter, and then cover the wound. Often we are so botched up by, oh, it's so extensive. Is it first degree, second degree? Let it all take its place, but fluid resuscitation, I think, and pain relief. These patients are really in a lot of pain, and that's again. Maybe it's a challenge to get morphine. Give tramadol if you have Fort Win, Phenergan. That's something that's used in rural areas quite a bit. Give that. Midaz, if you have, please give that. Take care of the analgesia. Give them supplementary oxygen. Give them IV fluids. And uh, despite the best counseling, some patients say, no, we are okay if the patient dies here. We don't want to go anywhere. This is what happened to this patient. And that's where the step of your dressings and all come in. So I was just so as he mentioned, we've taken this. I was so inspired by the way this case was managed, and I thought a lot of people should know about how extensive burns can be managed in secondary hospitals or even primary in this case. And we in fact wrote up, and it will get published soon in BMJ case reports. And the first thing the editor in chief said is one thorough debridement. Do one thorough debridement and try to cover with whatever you have. And if you don't have anything, cover the patient in honey and put a mosquito net around the patient so that there is no secondary infection. So for that one thorough debridement, you may lose like 1.5 liter of blood. So where is the blood going to come from is the next question. So that's how you need to think. In Goodlure, I would have taken the patient to theater, debrided thoroughly, because I know we have a blood bank there, and I know we can get all sorts of dressings there. But where Sankalp was working, there was no anesthetist. There is no operation theater. There are 2 or 3 staff who need to be taught how to do dressing. So there, what step they took makes sense. Minor debridements every day.
Okay.
Slow, steady, minor debridements every day. Okay, today it looks good. Tomorrow it's looking a little black. Let me scrape it. Let me give some analgesia and just debride that region. I'm not going to do extensively. I'm just going to do thigh today. I'm going to do forearm tomorrow. I'm going to do trunk day after tomorrow. That's still okay. And second thing is when we I need to get silver sulfadiazine to cover the wound. A tube of it costs some 500 rupees. Don't. A jar of nitrofurazone, a yellowish looking ointment, is about 30 rupees. Use that and cover the patients with that. And also, I mean, if you work in areas surrounded by forest, I'm sure your friends are happy to donate a can of honey. So cover the patient with honey after you do the
I
requirement.
think resource adapted guidelines is the need of the hour, and I hope
Absolutely. Yeah.
someone like Roy takes the lead along with Sankalp and everyone. We now have someone from the rural areas of London joining us, Dr. Murtuza, who has been one of the tremendous help on the WhatsApp group and has always been accessible to help the students out for this thing. Murtuza, thanks for joining. From your side, from an emergency management perspective, and as Sankalp also mentioned, the sort of unique status of St. John's in managing burns patient, I'm sure during your post-graduation and later on as a faculty, you have seen many patients. Very quickly, 5 points that those in rural service should keep in mind.
Well, I don't know if I can count to five properly, but I'll just say Royson summarized everything well. I think sometimes we forget that because the pain is so severe, we are thinking of Fortpin Fenergan because that's what we have in rural centers. The good old-fashioned paracetamol and a diclofenac, because they work through different mechanisms. We are thinking of opioids because the burns are so extensive. Nice to always keep in mind paracetamol and diclofenac work through the anti-inflammatory pathway also, which is a great help because this is inflammatory pain, isn't it? I like what Royson said about midazolam, because 50% of the problem is the pain and 50% is purely the anxiety that a burns can bring. So I think that's a fantastic suggestion. From John's, I also noticed the fact that I obviously had a very kind boss. Sometimes you can't fix the burns in the emergency department. You get too calculated in trying to figure out Parkland's formula, all of that. I think starting some fluids is better than starting nothing by only spending your time thinking about what to do. Uh, of course, Parklands is a good starting point. I personally, because I believe that when, like Sankalp has already mentioned, that above 40% burns anyway has poor outcomes. My entire brain was refocused when I saw 40-45% burns, saying, okay, I know I can't do the best in terms of doing a clean dressing because it's just too labor intensive or expensive. Let me just focus on the pain management. And what I started doing, and I don't know if it was, I think it was received well by some of the senior people with more wisdom, was to give them ketamine. How do you get a 30-40 burns patient to move about for all your dressing? I gave them ketamine. For 15 minutes, I timed the junior doctor saying, we've got ketamine, it'll work for 15 minutes. Quickly bring all your bring all the equipment. We clean the wounds to the best of our ability. The patient's not going to move for 15 minutes. Finish all the bits, let them go. Cheap drug ketamine, safe drug ketamine compared to your propofol, where you're already thinking hypotension, fluid loss, all of that. Uh, Opioids and all, you to the extent to get them to be completely quiet, you need a big dose. You can't take that risk. Ketamine. I think that's more than 5 points. Thank you very much.
Sankalp, if you could just summarize as to what happened to the patient on follow-up and how the recovery was.
So, with like we were pretty dedicated in our management with this patient, with serial investigations every third day and few investigations every day. And also there were times when the patient was there was a time when patient developed delirium, so it was very acute. So I was actually very scared because the patient might go into sepsis right now, and sepsis is one of the most dreaded complication a patient might have. If this patient goes into sepsis, I knew I'm not going to save her. It's difficult. So what I did was I vamped up the dose. I started on an antiviral. I started on a antifungal, and I prepped up the antibiotics. I covered the meropenem. I gave an meropenem. Usually, it will cover the extended spectrum beta lactams. So in a couple of days, next 2-3 days, the patient came out of it. Patient fever also subsided, and the patient came out of the whole phase. After, like, the patient was here for 1.5 months, every day with everyday dressing and medications. The patient was very poor, so the patient had to eventually be discharged against medical advice. We counseled the patient to go to a higher facility or to a government facility, but unfortunately, as like Dr. Royson will shed more light on the infrastructure, abysmal infrastructure we have uh, uh, regarding burns treatment in India. we didn't find any beds. So that's what we offered the patient, that if you can bring the patient every second or third day. We were bargaining with the patient. You can bring every second day or third day. We can help you out. We can see at least the urine output. We can monitor the patient. But the attenders they were pretty poor, and he had recently lost his job. So I didn't pressurize him. The patient was discharged, and I found out eventually within like 2.5 months, the patient expired. uh, One of the patient's like sister-in-law, if I'm not wrong, she was the one who was a regular patient of mine. So I got to know her, that she's a relative of her, and I asked her about her. She told that her wounds became very infected. It became foul smelling and it became yellowish. Her tube became all turbid, dark color. So I thought that it might be sepsis secondary to infections only, and she eventually succumbed to her injuries. But this journey, this 1.5 to 1.5 months of journey was like, with her also I learned a lot.
And
And
that's something which we can see when you're
it
talking
it's
about
like
it.
small little things matter. Small little things you can do to save somebody's life. And like, I hats off to Johns for giving me an opportunity. I never knew that being a rural bonder, I can be exposed to something like this. I thought that all those movies you see, oh, it will be, you won't have electricity, you won't have this and all. I thought I used to romanticize them, but now when I'm in the real life, I'm crying. This is the reality. What When the reality hits, but through thick and thin, uh, all of you guys helped me out, and especially Mihika. She does help me a lot every day with Dharma cases. Royson, every day he helps me with. Most of the days he helps me with surgical cases. Motuja is very active. He's very happy-go-lucky person. He's very
So we are not
active. He
doing
keeps
this as
on
a thank. We are not doing this as an
posting things
Oscar
on the
thank you
group.
speech. But Sankalp, we are very, very proud of what you have done, and we can see the sort of pride and accomplishment you have when you speak, and especially when you say "my patient." It always establishes that sort of gratification and responsibility you're taking of the patients. Royson and Murtuza, just to
Yeah.
sum up this last part before we are joined by a very special guest, Dr. G.D. Ravindran, who is joining us in very short time. Royson and Murtu, I want you to sum up two different aspects.
Hello.
Um, Roy, from a surgical aspect, what should a rural bonder keep in mind when they see a
Oh,
burns patient? And
yeah.
Murtuza, how should the counseling be done when someone sees this patient? Roy and then Murtu.
Yeah, thank you, Nitin. So, just for everyone on this session to remember that this patient that we managed would have probably died even with the best care possible in the best center in the country. Remember that. It's not because the patient was managed in a rural hospital that the patient died. The patient would have died probably much earlier, would have died with a lot of debts in their bank accounts, with land sold and children's education on hold in another hospital, in another private hospital. This is a key, I think, I want you all to remember. And it's very sad that the reason patient died, yes, I know it's sepsis secondary to infection of the burns wound, but why did the patient die? The patient died because she couldn't get access to a basic dressing. Someone in our wide big country, someone couldn't get a dressing after about 1.5 months of being managed in a hospital. When the patient got discharged, she just couldn't get daily dressings done. And if you don't dress a wound for 5 days, obviously there will all sorts of infections are going to happen. And this is which is what happened to the patient. And we empathize with the husband who couldn't bring the patient, but in his defense, he said he had children to feed. In fact, I think if his cow was sick, he would have taken better care. I mean, that's really what happens in our country, you know. So remember, Sankar, we've done a fantastic job, and I'm sure a lot of you will see these patients. And sometimes they say we just can't go to a secondary hospital, and these patients may be with advanced cancer of the liver, or someone with hemoglobin of 4 who's 100 years old. There is really, it just takes, I think Murtuza will add on to how to really talk to those patients. Sometimes you just have to sit with them and say, listen, if it was my grandfather, I would have taken him home. Someone with cancer with all the lobes of liver with bilirubin of 15 is not going to make it even in Mayo Center. There is no point your entire family taking all these efforts and taking the patient to a tertiary care. So that's again another aspect that you're all doctors now, and everyone will take your word for granted. I mean, will trust your word for granted, and we all are proud to be to have come out from such a good institute which puts ethics before everything else. So take the ethical route. It's all right. Patients die sometimes, and remember that patients should die with dignity, and patients should not die for no reason. So when you counsel, remember these two things in mind. This patient definitely would have died anywhere. I feel the kind of presentation that the thing
I think,
had,
like
but
you rightly said, very, very important point to have the last word to Murtuza. How do you counsel such patients? 5 points to keep in mind when counseling patients in a rural setup.
Again, as a reminder, I'm not good with counting, but I can just say two important things here. One is what Royson's mentioning about they would have died anyway. When you already know that, then your approach changes. And I have become a bit more, let's say, dramatic towards this kind of approach, because now I stop thinking about, as a doctor, what are the things to do. I just take a step back saying, if I was the patient, I have 40% burns. I don't know that I'm going to die. I still think, because I'm talking, breathing, I think I'm going to live. But somebody has to tell me that you will, but it's a matter of 10 days, 20 days, 30 days, I don't know. And that's so important for me to know, because I'm an intelligent person. I want to plan things before I eventually die. And keeping that away from me, I would say, is the worst thing you can do uh, to me. So in various ways, I've learned over the last few years to move into that kind of thing. Start telling the family honestly, we're looking at this much time. Start telling the patient. Of course, there'll be some denial, typical denial, anger, bargaining, depression, and hopefully the acceptance comes. And when patients and family go in from the denial, anger, and all of those things into proper acceptance, they come up with some beautiful plans. And the dying part can actually be very, very, very beautiful, simply because everyone's understood everything. They've got a logical plan. Before I die, I want one, two, three things. And they may be the exact opposite. The family is thinking one, two, three in a completely different plane. The patient is thinking one, two, three in a completely different plane. And if you hadn't told the patient, the family will do what they think is best in the last 10 days of this patient's life. But the patient wants something exactly opposite. So this is something that I cannot mention any further than just say, pick up the book. When I left my ICU, where I was forcibly made in charge in a underfunded hospital in Mumbai, which had never had a consultant level doctor in the ICU for 8 years, I was the first one who picked it up, because they don't pay in that hospital. When I left behind 2 copies of Atul Gawande's book. And that 2 copies, I just told people, it's a storybook, man. It's fun. Just read. He talks about his own father's neurosurgical tumor, and kind of stories his own father comes up with. You can't imagine that this is what people in their end of life think. So I think that's my suggestion. The book. If you want 5 points, I'll say Atul Gawande book, Atul Gawande book, Atul Gawande book, and you know the rest. So that'll be my thing. And just on the end note, just to say, as a learning for me personally, apart from all the drama which I love and the soft skills, I learned ketamine IV in St. John's, because St. John's is a beautiful center. I don't know if most people know. From emergency medicine point of view, how much ever you like to criticize it, it's way ahead of its time in the rest of India. So I learned ketamine IV because that's the standard. I went to Iraq during just post-war, and there I was shifted near the border of Syria for 2 weeks. And there I had to manage follow-up of burns. Now that's something I've never done, follow-up of burns. So I didn't know what to do. They gave ketamine IM. I was uncomfortable. I've never done it, but I was pushed. I read up ketamine IM, how it works. Apparently on the follow-up, every whatever 5th day, 7th day, patient keeps coming in. They give ketamine IM. They do the burns dressing, especially if it's about 10-20% or pediatrics. So that's something learning even at whatever stage, to learn that same drug in an IM version in a limited resource setting. You have to push yourself, learn it. What can happen? It's not going to kill the patient. I'm an emergency doctor. I can handle that. So cheers.
So very important points brought about. Thank you so much, Sankalp, Murtuza, and Royson. We are going to collate these videos, and we will take your inputs as to some pointers we can put in. Thank you so much. Royson made a very interesting point, and that was, this case is going to be published in one of the BMJ journals, and that's a very, very remarkable thing which is happening and something which can happen in the rural service. And I think with Royson's collaboration and cooperation, we are now soon going to be hosting one session on how to publish and how can you really take up research even during rural times. Thank you so much, guys. And
Just
it's
one last. I'd like to end on a positive note. I mean, it's a positive note anyway. But just don't forget, one of the key aspects to manage burns is hydration. So hydrate the patient well. But even more important than hydrating the patient is hydrate yourself. Your brain will work if you take care of yourself. Keep drinking water, drink a juice, drink a tea, and when you're calmer, you'll make better decisions for your patients. So take care of yourself.
as always, promoting wellness. Thank you, Dr. Murtuza, Royson, and Sankalp. We are now here for one of the most awaited parts as such. I would like to invite on stage Dr. Anthony Robert to welcome our special guest for today. Dr. Robert, we can't hear you. No, we still can't hear you. Maybe you can rejoin in. No, we can't. I think you should log out and log in. Right, the special guest is someone who is not a stranger to those in St. John's. He's someone known across all batches. I have been very, very fortunate and privileged to have had him as my thesis guide, and later on as well. He always is someone who looks after his students. But more than that, he has always been a treasure trove of stories St. John's, of the good old days of St. John's. And always, what I used to like when doing rounds with him is any corridor, any small incident of St. John's, he used to share those nuggets. And today it's my fortune and privilege to invite Dr. G.D. Ravindran. Needs no further introduction to any batch in St. John's. Sir, thank you so much for joining us. Can we just have a brief mic check from you?
Thank you, Nitin,
Yeah,
for nice
perfect.
introduction that you have given me.
Yeah, thank you, sir. Good to see you surrounded by books as always, even in your background as such. You were one of the first few batches of St. John's which went into rural service. So if you can just describe how those initial years was of trying to do rural service.
See, times have changed. In 1973, if you remember, St. John's, once in 10 years, has a review of its mission goals, whether it has been achieved or not achieved. So every year, every 10 years we have had. In 1973, they had 1963, St. John's was started. 1973, a first review of St. John's was made. And during that time, there are two changes that they brought about. One is they stopped private practice of all the doctors so that they'll spend time in teaching. Because during our times, after 11 o'clock, all the many of the senior doctors who had practices would disappear from the wards. So when we are practicing in Marthas. And the second thing they said is we must introduce compulsory bonds, 2 years bond. And government was just thinking of introducing it, but St. John's introduced it. So the first batch which had the bond was 1973 batch, and we were the second batch, 1974 batch. And 1973 is a peculiar thing because only 30 students were there, and our batch was 58 students were there, and nuns did not have the bond, but others in the batch had a bond. So the first Johnite who went to do bond was Dr. K.R. Anthony, and he went to Manantawadi to do bond and he used to write stories about what is happening in thing. In our batch, we were, if you live the 9 months, we are about 60 students. And when the bond came about, those days you could defer the bond without paying the money, as long as you said that you're going to do a post-graduation, because you were the first batch. And St. John's had not seen all the tricks that students pay with the bond. And at that time, the bond money was only 5,000 rupees. Okay, so only very selected people who had an inclination to do the bond did the bond. And in my batch, I was one of the few people who joined the bond immediately after joining the internship. And at that time, we had CM Francis as the dean, and he had Dr. Ravi Narayan, who was in community medicine, who was also put in charge. And what they did was they screened the whole of the country and they selected bond centers. And there are about, and they made sure the bond centers had place for us to stay comfortably. They also made sure that we had basic facilities, that is, the basic lab facilities as well as inpatient facilities and outpatient and sometimes outreach. On that basis, there are about 5 centers in Karnataka, and north, I don't think there was any center that was there. And in the south, then Kerala, there were a few centers. And when they started the bond system, we had Dr. Prem Pais and Dr. Ravi Narayan. Ravi Narayan used to take care of all the administrative problems, like negotiating with the hospital to pay salaries, whether they're paying regular salaries, whether food is taken care of, any other problems that we have. Dr. Ravi Narayan would negotiate, and all the medical problems would be directed to Dr. Prem Pais. And remember, in those days, we never had phones, we never had any of these modern gadgets. The only way was to write letters.
I was just coming to that point, sir. Very challenging times. Today we have up to date Google, WhatsApp groups, people even approaching faculty on a one-on-one basis. So, where did you do your bond, and how were the initial days when you entered your bond center?
I did in a place called Kamagirai, which is about 80 kilometers from Mysore. It is on the way to Hills and Mysore, and it's a Veerappan's territory. In those days, Veerappan was a small fry. It was Veerappan's territory. So I did the bond there. And before I went to that bond, that center was a leprosy center. And as because the church handed it out over to the Holy Cross sisters, and they said, instead of running a leprosy center, we'll start a general hospital, and they started the hospital. So we had about 8 beds. We had a labor room, and we had an outpatient. That's how we started. And like you said, those days communication was a major issue. So when you write a letter to the Prem Pais or Ravi Narayan, you would get a reply promptly after 10 days to know what is to be done, what this can be done. There was also other places where you could still access knowledge. That was the Indian Medical Association meetings that used to happen in Kolnagar. And once a month, we used to go there and discuss and exchange what is happening, what is not happening. And the third thing that we helped me to keep up to date was British Council. Now, British Council at that time had a postal library. I could write what books I want, and they would match. Suppose he asked for some book like Harrison or something to handle burns, and they would see if I write something, and if they did not have the book, the librarian would send an appropriate book which I could read, and after a month, I could parcel it back to British Council in Madras, that is in Chennai. So that's how we used to keep. And one important thing, don't give up reading. It doesn't matter where you are, what you are, however it is. Forget about the exams. Read in relation to the patients. Like, for example, if you had a burns patient, you go and read about burns and you see how you can help the patient to feel better. In those days, when we had burns, one of the first biggest headaches that we used to have is patients used to have hematemesis, until I discovered that burns can produce ulcers in the stomach, and we used to give them high. Those days we never had PPIs. Only that we had was antacids. So we used to pour the tons of the antacid to give them to drink, and we used to manage patients. And of course, we would have IV fluids also. You in the villages, you have to think 10 times before you give IV fluids because cost becomes a major issue for patients managing patients. Okay, so that is how we began. And once a year, once in two, actually it happened twice. Once all the rural born people would come to St. John's and they would have a discussion among themselves. And at that time, the management and the teaching faculty were so open that representatives from the rural born would go and tell the staff what is missing in our teaching. Now, if
I think
somebody goes and says,
very important feedback, sir. Yeah.
because people will say we are more interested in dealing how to deal with children with nephrotic syndrome who come like this or something like that. Some issues they'll raise and would be presented. It happened twice when I was in Lavon. Then it happened in 82, again in 84 when people took over. And in 84, when I mean, not 84, I think 85, Ravi Narayan left. Prem Bhais also left St. John's for a short period of time. That is when this whole system of support disappeared and it went to the director for managing the students.
So, what were your initial thoughts, sir? I mean, just from a more personal question, if I can ask, when you went to the Bond Center, what
No,
was your thoughts? Were you having
no, see,
apprehension?
no, the problem was after you finished ABBS, like most of you, I did not know what to do. Everything looked fine. And I had a family physician, Dr. Narsimhan, who called me and told me, see, God has given you a good opportunity. Go work for 2 years in rural areas, you will become a better doctor. And I listened to that and I went. And I really thankful for him and for his advice because that made me a better human being than what I would have been if I was in a hospital doing my post graduation or things like that. So I enjoyed every minute of that 2 years that I mean 5 years that I spent there, and I would have continued there apart from other issues that raised up and I had to come back.
Any challenging cases that you remember which you came across, or anything which stands out? Any cases which, or someone, I know you have patients who have been coming to you for follow up for almost 20-25 years. Anyone from your Bond Center who also came to you on follow up later?
Many of them still come today, but now what I see is the children and grandchildren coming to me to see.
Okay. Okay.
Okay, that is something which is very very fulfilling. And one reason I realized was unless you give good medical care, none of your preventive works will work.
Very
Whatever
important.
you may say, people will not come. And that is because in the first month, 2 months when I went, when antenatal checkups would not be there, people will come only with one complication. Okay, and one day they used to give free food. This thing, no, they used to have milk distribution for children, and one of the patients landed up with eclampsia, and she used to throw on fitting, and the sister in charge will tell, see, she had not come for this thing, that's why she's suffering. Luckily I could save her and also deliver the baby, and after that the reputation went round and we used to get antenatal mothers. So it is important that you should be very good clinically to diagnose and treat. You may have
How
100
many how many deliveries did you do during rural service, and were you inclined to any time take up OBG for post graduation?
See, I do not think I know whether present day any of you have seen forceps. In the 5 years that I was there in forceps, I must have done about 100, forceps deliveries. Okay,
Wow,
and
unimaginable number.
pardon? And
Unimaginable number, I said.
one year later, I mean after 2 years later, I again went back, and all the ladies whom I had delivered by cesarean, I'm sorry, forceps for the first baby, the second baby we had a surgeon, all of them underwent cesarean sections, and then started the problems.
Okay. Anything which sort of any scenario comes to your mind where you were stuck, you did not know what to do with the patient, but somehow you were able to overcome the
Oh,
challenges?
that will be a regular feature, no? That's why you have to keep reading. You get stuck, then what do you do? Then you play by ear. What is the likely diagnosis? What to do, and things like that. And you have to that humility to learn from people, patients, and the surroundings. Like for
Any
example,
particular case that comes to your mind, sir?
no, that's what I'm going to tell. I used to went maybe in the second year or something when I was there. Every Tuesday, I used to get girls, young girls, who will complain of severe abdominal pain, and the whole family will say, "Give one bottle of IV fluids." Okay, and I say, "Why give IV fluids? We'll manage like that only. Give Buscopan, this and all that." Then in the evening, the sister will say, "Sir, she's getting dehydrated, doctor. Why don't you give her a fluid?" The minute you started IV fluid, patient became all right. So after some time, then this was a regular recurrence. Then I asked somebody, "Why are you asking for IV fluids?" Then they said, "We went to the temple there, and the pujari there said, you go to this church hospital and take 2 bottles of IV fluids, your pain will disappear." So after that, any time patient came with any pain, and the first question I asked, did you go to the Sani Mahatman temple? If they said this, what did he say? Give IV fluids. Give IV fluids and send them off. Like that you pick up a lot of things that you would not pick up in a hospital where you have all the diagnostics and all that. Just been spending those days, it was 10 rupees for an IV fluid. All their problems would have been solved. If it was now, we would have done an ultrasound. You would have asked for this, that, and all that, and patient would not have got better.
The
Okay, so
placebo
you'll learn.
effect,
Pardon?
the placebo effect that we always talk about.
And when I was in the third year, I had a friend of one of our juniors who joined me as a thing. And there, what used to happen is every day patients used to come and ask for injections. And there'll be a big fight. Why should I give injection this? And when he was there, when he joined, the first day he joined, he saw a patient dying of tetanus. Then he decided anybody asks for injections, give one tetanus shot. So that by the end of 9 months, the whole community is filled with tetanus. So you need to innovate according to, at the same time, you must be scientific when you innovate in these areas.
We have one question coming in from Dr. Prithvi, and the question is: in today's era of NEET PG and postgraduate entrance exams, sir, would you advise students to still do the rural service? If yes, why? If no, why?
I would always advise people to do rules by your service immediately after they finish the MBBS because it develops confidence, it develops your worldview better. Okay. Second thing is, if you are doing rural service also, it tests your capacity to study. There's no point that everything is free, you are studying. When you go back into the world, you are going to face problems and you're going to see patients and you have to study. As a doctor, it is your duty to study. So what's wrong in preparing for entrance exams as you go on with that? Other thing that I find which is difficult for the present set of students is all of them study singing and all of them talk only about multiple choice. So today I just finished my DNV examiner. One of the examiners said, "Sir, we don't have thinking PGs. We have only MCQ PGs coming now. So it is very difficult for medicine to practice." So it doesn't matter. You have to make time. You have to sit and read because there is always a this thing. See, to expand what I'm going to talk about it is when you are in the hospital in Martas, every third patient was a rheumatic fever. So when I went to the village, I never saw one rheumatic fever for 3 months. Then I got scared whether my diagnostic skills are going off or what. Then I went and asked a senior physician. He said, "Oh, rheumatic fever and all you will not see here. They'll come with sore throat. You give them penicillin, the rheumatic fever would have disappeared." This was in 1970s before the incidence of rheumatic fever came. And that is when he said, you should study. And you study only if there is an incentive to study. That is why at that time there was one thing called Fellow of College of General Practitioners. You could practice anywhere. It was this thing exam run by the IMA. So I sat for that exam because I had some intention to study. I was not planning to take up medicine. And when I finished that FCGP exam and passed it, the local general practitioners here asked me to do the DNB. And that is how I did my DNB in family medicine even before I did my MD in general medicine.
And that
So
is something remarkable, sir. Yeah.
it depends on the drive that you have.
So a question from Murtuza, sir. Do you think in today's, again, in today's day and age, do you think, like you mentioned, it is just someone's inner drive and passion which will drive them to rural service? Or do you think, looking more from a practical aspect, if the service compliance and desirability will increase if it was 1 year instead of 2 years?
See, 1 year instead of 2 years, then it'll say 6 months is instead of 1 year. No, it doesn't matter. But it's, if you see pedagogy wise, 2 years is necessary to form somebody into a person. You do not have a diploma for 6 months. No, all diplomas are for 2 years if you have to train people.
True. So there was one more question, and I want you to reflect on this from your rural experience. Samrat had actually addressed this question to Dr. Mihika, that how do you manage patients in rural areas when they insist on certain medication or topicals? That is one of the common challenges, and everyone says, we have been taught this evidence-based medicine in St. John's. We have been taught this, that. I don't want to give antibiotics for a 2-day fever. How do you communicate this to patients in rural areas?
See, first and foremost, you must be good in your clinical diagnosis. You say, I will not give any antibiotic today, and after 2 days, you give him an antibiotic, he'll lose his faith in you. So they say, ಅವತ್ತೇ ಕೇಳಿದ್ರೆ ಯಾಕೆ ಕೊಡ್ಲಿಲ್ಲ ಇವತ್ತೇ ಯಾಕೆ ಕೊಡ್ತೀರಾ? So you must be very clear about your diagnosis, and sometimes you have to pander to patients' thing. You don't have to give antibiotics. You can give a multivitamin injection, or you can give a diclofenac injection. Patient will not know whether it's antibiotics or no antibiotics. No, that's why I told you my colleague Kevin Maskiness was one who started giving immunization to all the people, and they'll get their in the DPT injection. They get fever one night. Next day they'll come and say, "Oh, all the body pains are gone after we got the fever."
Okay. So again, it comes down to counseling and understanding the local culture and the
Yes, it's
needs.
very important. Local culture needs to be understood.
Okay, sir. A little bit of a fun question, sir. People are saying that there was a nickname given to you during your rural service. If you could elaborate on that.
you do, you don't wash all those things in public, no? No, yeah, I'll tell you what happened. When I went the first week, when I went there, people were curious to see who is this fellow from Bangalore coming here. And they saw that I'm fair. So all the ladies used to land up. So they used to call me Kempo Doctor. So that's how that name went on.
Right. So I mean, you're legendarily known as GDR, but there are of course also who call you as Kempana or the Kempo Doctor as such, and you've always been an inspiration. So lastly, so and this is something that as the alumni committee we are also working on. Once you came and joined back St. John's as faculty in the era before WhatsApp and all, you were also a great support and still are on many occasions to people serving in rural areas. What were some of the most common challenges which you encountered that they used to report to you?
It's how to handle the management as well as sometimes how to deal with patients. It is not so much the medical problems that they are worried about. They know TB, I'll treat TB, but how do I get this patient to take medicines for the 6 months of the TB treatment? That is where the challenge lies, no?
Sure, sir. Absolutely perfect. You said you did your DNB family medicine before doing medicine.
Yeah.
If I was to again ask you for a specific instance of a case you encountered in your residency or even when you became an SR or AP, something that you saw a case and felt that, okay, I did this in my rural posting or my rural service. That's why today I am able to recognize this diagnosis or come upon this treatment. Maybe a treatment of cholera, one story you had told me, or something like that. Anything?
There are many stories like that, no? You cannot, this thing. One of the things is to identify tracheoesophageal fistula in the emergency. Because those days when you're in medicine PG, you would be sent down to look at the emergency. Now, we used to run the casualty in those days. And the child came and said, "Oh, this child looks like a tracheoesophageal fistula." And there was one pediatrician called Raghu. He came and he examined and said, yeah, yeah, how did you make it clinically this type of diagnosis? So there are so many stories like that.
Right. So possibly I'm going to invite Dr. Anthony Robert back on stage. If we can have Dr. Robert. I
Hi,
think
Nitin.
we,
Can
we,
you
we
hear
have
me?
a treasure trove of stories from the experience, Dr. Gidia. A few words from your side, and we will let Sir go because he has one more commitment.
Hi, Nitin. Can you hear me?
Yeah, perfect.
Wonderful. Dr. Ravindran, thank you so much for joining us today as our opening faculty batsman. It's for me, it's a great privilege to talk about him because I was an undergraduate student of his too, though he looks like my colleague now because he hasn't aged and I significantly have. So I remember him right from those days in Dr. Moira's unit and then A and B, and he was part of the team which used to take our pants off during our internship. So I have many stories to tell, but I'm not going to take up the time today. But thank you, sir,
Mutual, Robert.
for your
It is
experiences.
mutual.
And I have visited Kamagere, and I've heard the stories from the sisters there because one of my classmates did his bond there, and I just went to see that. So thank you for sharing your words today. And I also want to thank Royson and Murtaza for their.
We are not yet done. We are not yet done.
Oh, they're coming back.
Dr. Gidia, if you could just give one message to all those doing their rural service, and we will let you go after that.
Don't take anything for granted. Okay,
Alright.
whether it's patients, whether it's a management or yourself, always
Right.
question and do the right thing.
And what do you think? Many times, many of them wonder: Are they doing the right thing by doing the rural service? Are they being left behind? What would be your message to them?
See, it does not. Medicine is something which, it's your capacity that matters. Okay, you may, if you are going into a this thing, what you call academic line, then time matters. But if you are going into practice, time does not matter. See, now, for example, if your colleague has finished his MD 2 years before you, and he has joined, you will be 2 years behind him whenever it goes to your academic thing. Like you will be a professor, your classmate would be a professor 2 years before that. But if you go into practice, this does not matter because patient only wants one thing: I'm sick, make me all right. He does not worry whether you are a gold medalist or you have spent 10 years passing your MBBS or you have taken more time doing that. It's only
Absolutely
the
wonderful.
academic people who will land up. Yeah.
Wonderful words of wisdom as always, sir. We look forward to having you back on more such podcasts or videos to tell us more stories. Thank you so much for taking time off at such short notice, and we will
Thank
hope
you.
to have you back soon.
Yeah.
Thank
I'm leaving. Thank you.
you. Sure. Thank you, sir. Thank you. Right. If I can just have Royson, Mihika, um, Sankalp back on stage. Murtuza, if you're there and you would like to join, please do come back on stage. Right. So just want to take some questions which have been coming in. And one point which was brought about, and I think even Dr. Tony Rahul has mentioned 1 year of rural service is better. Roy and Mihika, what are your thoughts on it, having gone through this yourself?
Mika, go first.
Uh, Retrospectively, I don't think it made that much of difference because you might think you're 2 years behind your batchmates, but you're actually only 1 year because everyone sits and studies for that first year. And quite a few times you'll realize that some of your batchmates who haven't done the bond have joined PG even later than you. So, in terms of getting back into Johns, if your plan is to get back into Johns or to maybe go to CMC, I think the 2 years is what's going to get you in. In terms of fatigue, I do know towards the end of 2 years of bond, this is on a personal level, I was very burnt out. I was very burnt out and quite fed up of the whole thing. It can be very isolating. So, if you feel that you're the kind of person who's going to burn out, I know I have a couple of batchmates who have done 1 year of bond and then paid it off. So, they've got some of the experience and then they've moved ahead.
So, living apart from the aspect of getting into a PG aside, Roy, do you think 1 year is good enough to get an experience, or do you think, like Dr. GDR said, 2 years is what is necessary?
Yeah, so I think I agree with Dr. GDR on that. It also largely depends on the center, but most centers, I think for you to just get used to the working and everything gets about 3 months. And then when you are getting used to the center, even the center is getting used to you. You're a new doctor to them. You don't know the language. The nurses don't have the rapport with you. And then in another 3-4 months, if you are just seeing patient and then take some time off for your studies, I think it doesn't make sense. So what I told my junior doctors is, first year, read all the books to become a good doctor. Second year, you can always read your entrance books along with these things. So I thought that made more sense.
Okay. Is Sankalp there? I'm not able to see him. I've added him, but
Hi.
yeah. Hi. So I don't know. I'm getting a lot of messages from Samrat that I've got your spelling wrong. But anyway, what do you think are the challenges that you guys have? You're almost finishing your bond, if I'm not mistaken. What are the challenges that you seem to face right now, which you think that as alumni and senior Johnites can help? And first of all, is there a need? Is what we need to understand.
Need for the bond.
No, need for help from external sources.
Okay. I got that wrong, really. So the thing is, of course, external sources, we need the help. I get all the help from Mihika. All my dermat cases goes to Mihika. All my surgery cases goes to Royson. Uh, Motuja answers most of the emergency queries on the group. So we do need a lot of support from you, from seniors, from like people who have lot more experience than we are. We are just getting started in this field, and most of the time we feel lost because it's such an overwhelming, like there are too many patients and too many problems. So in this thing, it's very overwhelming. So we do look up to you guys for support, and we do need a constant support, guidance while practicing too.
So the reason I asked you that question is, and this is something that Murtuza, me, I think to an extent, Roy, me, kind of definitely Prithvi, we would agree, is we have sort of seen a change in the sort of trend on the WhatsApp group that we initiated for this thing. That nowadays, is it the trend that you prefer a more of a one-on-one support system? And is there some amount of shyness or intimidation to post in the groups and encourage collective learning? So we are just trying to make sense as to how really best we can give the support. So if it's a one-on-one support, we need to put in mechanisms for that in place.
Uh, uh, of course, there is a component of shyness here. The people in like most of the batches, they are shy to come up with the questions, especially if there are 400, 500 people watching. So that's also one thing that comes. So what we do is for Doormat, I'm gonna text Mihika. For emergency, I'm gonna text Murtuja. We personally text them. So, but again, uh, the learning part doesn't happen here. We don't collectively learn.
Because I think
So,
if Roy, Meka, and Murtu remember in the initial days, let's say from 2013 to 2017, there was a lot of learning which was happening in the group with every case which was posted. And the other feedback that we get is, I mean, I don't take much of medicine doubts right now, but at some point of time when you message people individually, there's also a burnout or a sense of over responsibility which happens to the people on the other end, where it doesn't happen. So that's where we are trying to see how best we can continue this support in a very efficient manner with learning. Murtuza, your thoughts on that?
No, I do agree. I think when I get personal messages, I try my best not to. I tell them that put it on the group, you will get my response. The only reason I do that is because I tell them it has to be collective learning, and I don't want to be individually, feeling that heat. Because, like you said, you don't want to feel individually responsible on the other end also. So I think I've been requesting people to stick to the group, and I do understand that the problem may be two pronged. One is people feeling shy, and the reason for that partly maybe that this is just the generation that's shyer, but more than that, it's when the names get older and older, the connect is gone. So then your ability to be informal on the group and ask
Yeah,
goes away because you haven't seen these faces. You only know them because they're on the group.
I
So
still see my face at the interclass cultures, which I'm
I think
still
it's only.
judging.
I think that
I'm
maybe
sure
that's the
that we
problem
all see anyone else.
there. They're seeing too much of one face, but that's besides the point. The point still maybe that connect is gone. The second
True.
aspect to this problem, maybe like the person gets visible there, the one who's asking. I wonder if there's some form of technology where it may not be technology, it may just be logistic, in which the question can be asked through an anonymized number. So
Yeah,
we
I
don't
think
know.
that's what we are looking at that, because in Facebook and even I think even in Insta you can post comments anonymously, and I think that is something we need to look at if there's something we can do. Royson and Mihika, coming back to you so
I
that we
mean,
can wind
just
up.
sorry, just to
Sorry.
end that. Sorry,
Yeah.
apologies. It's just that because we look, at Code Blue, we always look at end-to-end solutions. You have to come to something at the end of a discussion. I'm just wondering, would it be okay if there was an admin phone number which just says rural bond, and questions go to that, and from that it gets posted to the group, so we don't know who's asked that question on the group.
Yeah, possible, and possibly I think given that you have told you could be one of the admins, and we could
Yes,
rotate on a
that's all.
fortnitly basis
As
as to
simple as that.
doing that and putting
So
that. I think that's a
it's
wonderful
four or
idea.
five of us. All we have to do, the admin has to do, is copy paste that message, literally.
Yeah,
Somebody
I think we
messages.
can do it in 10-day, 15-day rotations. I don't think it should be. That's a very good idea. Roy and Mika, coming back to you, what do you think should be the way forward for academic interaction with rural service bonders, and how do you think what mechanisms can be put in place? Roy, anyway, you have told about research. I think you should elaborate a little bit more on that, and then Mika can come in.
Yeah, so I think I always tell people that even if you think it's the smallest work that you're doing, that for someone else in another corner of the world it may be a big help. So this wasn't told to me when I was doing Bond, but I wish someone had told me. Keep a diary for yourself and just write down like the challenging cases you see, and it'll help you in a very, very long way. As an elaboration, as the next step to that, if you think that's something different that you've done or something challenging, reach out to people. So I am currently associated with BMJ Case Reports as Global Health Associate Editor, which specifically looks for these challenging cases, challenging scenarios, and something different. Like, so most journals are bored of, oh, this is different, oh, this is advanced, oh, this is latest technology. They want to sort of listen from third world countries or resource limited experiences. So I was talking to Nitin. I think we'll have a very formal platform where we encourage you to just write down your own version of the case report, and we'll have few people review them and then think that, okay, is it worth it? At what capacity is it worth it? In fact, I feel at one point we should even think of St. John's Rural Surgery Journal at some point.
Can I get Dr. Anthony Robert here? I don't know if sir is there, but if he can come on as such, because there's a point which you mentioned which I want to touch upon.
Yes, Nitin, I'm here.
Yes. So the whole discussion is, can we sort of work towards providing a platform? We always talk of St. John's and the St. John's Research Institute. And when we had done the Salim Yusuf podcast and the Ravi Narayan incident, we saw how steps to become a Rhodes Scholar was also taken from doing research in the community. So I think that's something we can work on, where we can, as an alumni association, we can possibly look at providing mentorship support and some sort of support to help the rural people engage in research.
Yes, I think it's by listening to voices like this on this group, on this chat, that new ideas like this do come up. And I think we as an association, and I'm sure in future as well, can put together a mechanism, but we need the inputs from youngsters. We need the inputs from here, because this is where it needs to come from. Because the current thinking doesn't, for us, this is new. So, and I'd like to build many things which are new, which are sustainable. So I'm really glad this point has come up. I think Nitin and Prithvi can persist in picking up points, and also picking up volunteers who will be thought drivers for this. Because then
I think we need people like Sankalp and most people who are actually doing the rural service now to sort of engage with those coming in, because you guys are the ones who are going to have a connect, and you could be the bridge between the support mechanism and those who need it as such. Mika, your thoughts on providing support in the clinical context?
I think there needs to be a little bit more streamlined way of getting the information across, because when I've spoken to them, they have two issues. One is sometimes we take quite a bit of time to respond. Like they might post a query and we might not see the query, and I might see the query in the evening. And sometimes when they just call and tell you, then you answer the phone. So you end up focusing immediately at that point and sorting it out. So it's quite exhausting on my end, because I get around like 30-40 cases sometimes in a day, in addition to my OPD load. But there needs to be some way of them streamlining it to say they know it's a dermat case or they know it's a surgery case, that much they're aware of. Maybe like subgroups which they can put it in so that it doesn't get lost in the translation, or a more official platform. Like, I don't know whether we can have like an official teleconsult platform wherein they fill in the details that we want to know. So then there's no me asking you 30 questions, or like, if they put up an ECG and then you all ask them, okay, how was the pain? How was this thing? So maybe creating proformas which they can just fill up will save some of the back and forth time that goes when they feel that they're stuck in an emergency and they're not getting the help instantly.
Sure. I think wonderful points. And I think Prithvi is obviously listening to this and sort of quite a bit of experience with Cloud Physician. And I think we can sort of brainstorm certain ideas with regard to how we can really take this forward. Right. So with that, I would like to end. Thank you guys so much. Thank you, Mika. Thank you, Roy. Murtu. Sangal, can you please pronounce your name so that I don't get scolded by Samrat for the same?
It's Shonglap. It's not
okay.
Sangal. So okay, it's fine.
I will just go back to Shakespeare. What's in a name? A rose would be still as beautiful if it was called by any other name. So what is your name you said again?
It's Shonglap.
Shonglap would be as enterprising and as energetic, whether it's called Shonglap or Sankalp, right? So I'm going to fall back on Shakespeare to my defense.
Can I just show something? I know we don't have time for me to speak, but it's just to
No, you
show.
don't. You don't. I'm cutting you. I'm going to be Arnab and I'm going to cut you. Okay, go ahead. Go ahead.
That's my diary. Even at this stage in UK, I write my cases here. You can see this is a real. I have headings and I write 2-line cases, only 2 lines. If I write more than 2 lines, I won't read it. So that's how I do it even now. And people think it's fantastic. People think, how is somebody at that level of seniority doing this at this stage? So the junior doctors and nurses love it. I love it. It keeps me grounded. I always look back. So thank you. It's a good idea, Royson. Fantastic. Oh, Hayward's 2000,
Batch of
Hayward's
2009 and
5000.
meeting batch of 2005 here. Right. Right. Dr. Robert, final words to you before we wind up.
Yes, a big word of appreciation for all the Johnites who contributed onto this panel. And of course, I'm so proud of Mehika and Royson and Murthu, who, though being far away from Johns at the moment, are still continuing to contribute. And I think the Alumni Association will find a way to appreciate you guys, and it's really, your impact is many fold, because you're impacting so many rural doctors. Thank you, Prithvi, and thank you, Nitin, for this initiative and for taking off. And we have to keep this going. And God bless.
Right. All right. Thank you so much. We will put out some forms of the video, and we hope to see and we hope that this session carries on further. Thank you so much.